My name is Amy Pack, and I'd like to start out by thanking NHLC organizers for the invitation to present on such an important topic, which is the involvement of patient partners in virtual health service delivery, and that is from these three perspectives. And I'm lucky enough to be joined by my two co-panelists. So Matsu Jackson, who is a patient leader and will be providing the patient perspective. There's also Laura Copeland, who is a clinician that wears multiple hats, and she'll delve into those different hats and how these hats are involved in virtual health service delivery. And finally, I'll close out the session by explaining how HSO involves authentic collaborations with patients throughout the standard development process.
So I'm going to talk a little bit about the role that digital health plays in my life and what I think it can play in a patient's experience with illness. First of all, my friends at HSO asked me to sort of talk about hemophilia a little bit. Hemophilia is a bleeding disorder. It means that we're missing a specific protein in our blood that helps us coagulate. So in our case, we don't coagulate. So for example, a severe hemophiliac will produce 1% or less of this specific protein, which is essential in the coagulation cascade. And this means that some common problems are that we'll have internal bleeding regularly. If we hurt ourselves, we'll have internal bleeding in the joints, in the muscles, and they can cause irreversible damage in the joints and in the muscle tissue. A little bit about myself. I'm going to start with my own personal trajectory, and you'll see where I'm getting at. So I grew up as a young hemophiliac in a world, what I call a world of moguls, in the sense that I was a spontaneous mutation, so it's already a rare disease, but I was even more rare because I was in a rural area when I was a child, and no one else in my family had it. My mother was not a carrier. It's passed through the mother. So I didn't have a long history of hemophilia in my family, unlike other hemophilia patients who do. So I was born in 85, but I was diagnosed in 86, 1 year after the tainted blood crisis. So there was an initial sense of relief in my family. But then later on, I also had a feeling of isolation. I had two younger brothers who were not hemophilia patients. I was a spontaneous mutation, and I'm a rare disease, and I'm also the rare variant of hemophilia, so hemophilia B, we're less than 10 in the province of Quebec. This is a little bit my road to patient engagement. Today I work at the Center of Excellence on partnerships with the patients and the public with Vincent Dumez, who is here, and I'm also very active in my patient community, but it took me a long time to get there. When I was a child, it was involuntary isolation. And then when I was a teen, I kept hiding my illness for a very long time. The pivotal moment for me was when I got kicked out of the basketball team once they learned I had hemophilia. So my treatment team was behind me. They said, you can do it, we'll take care of you, we'll give you enough products, etc. And then once the coach learned I had hemophilia, just before the season started, I was kicked off of the team. During my 20s, hemophilia caught up with me. After high school, I had two passions in life. One was literature, the other one was cooking. And my mother obviously suggested I do literature because it's much safer for hemophilia patients. So obviously I chose professional cooking. Professional cooking is an environment where there's lots of chances to bleed. In the joints, you stand up all day. So I had some very painful bleeding episodes. And also chances of infection. So I also had very painful blood infections because obviously you bleed longer, so you have more chances of being infected. So I had to revise my life project at one point. I had to take a hard look at myself. I remember I had a huge bleed in my left ankle, and this is important, it'll come back. And I was sitting in my couch after a long service as I was working as a waiter in a restaurant, and I realized, okay, I have to change something in my life. I have to revise my life project. So I went from manual to academic work. I started a BA in French literature, which I completed. And then I started getting involved with my patient community. They had study grants to encourage hemophilia patients to do more academic tracks than manual. So I met all kinds of patient advocates, and I discovered this whole world of patient advocacy, which I loved. It allowed me to meet Vincent Dumez at a conference, and then from the Center of Excellence in Montreal, and then I came back to Montreal, we had dinner, and now I work full-time at the Center of Excellence, and I'm very engaged in my patient community. But through my engagement, I started getting involved with MyCBDR, promoting MyCBDR. MyCBDR is an app. It's a self-management tool that was developed by a research team at McMaster led by Alfonso Iorio. Basically, it's an app that allows the patient to enter their data regarding their illness. So every time we bleed, every time we give ourselves an infusion, and it has lots of very helpful tools, and I'm going to show you some in a couple minutes. As a patient gets more engaged with their illness. So you can see here the stations of my progression through my life with illness, and then gradually got more and more engaged, more and more active in my own illness, but also in the healthcare system. And at the same time, my treatment evolved, my care evolved. The care was initially given by my mother. Then I had autonomy, but that's when I decided to isolate myself. And then I went through a phase of non-compliance because I was not putting into effect my treatment plan. And then eventually I took control, I became compliant, and as you'll see in a few minutes, really my quality of life completely changed. I have a lot less pain. I'm able to do what I want. I don't miss school. I don't miss work. So there's a certain emancipation from the illness. I used to be under the weather or under the illness, and now I'm really in control of it. From a clinical, self-management perspective, but also from a living with it, coping with it perspective. Okay, so that's what I'm trying to get at. And now I'm going to show you a concrete example of how this app helped me take control of my illness, self-manage, and be more engaged. So what you're going to see in the next couple slides, and then we'll be done, are graphs that a patient is able to pull out of MyCBDR. And these graphs were put there intentionally to help patients self-manage. Okay? This is a representation of my bleeds in 2018. So as you can see, I had one bleed in the left knee, one bleed in my left wrist, and I can say exactly why those happened. The left knee, I think I kind of jumped off a step, and the left wrist is from typing. So I bleed from typing in my wrist. And then I have 5 bleeds in my left ankle. So I saw this, and you remember that really bad bleed I got? So then I went to see most bleeds in 2018. So you can see in February I had 1, in April I had 2, only in April I had 2. Yet in November, and you can see it, the times when I use the most product is November and December 2018, yet I only bled once. This is the infusion. In blue, it's prophylaxis. So that's a regular daily infusion. That means I'm not bleeding. It's my day-to-day. In red, it's the first infusion you give yourself when you start bleeding. In dark red, here we have bleed follow-up infusion. So you can see in November 18, I bled once, but I infused myself over a week. That means that the bleed stayed and it wasn't not getting fixed. I can put notes, so treatment notes. And so, douleur persistante. And so I can say that there was the pain stayed, even though I gave myself my usual treatment, something was wrong. And the cause of bleed is also noted. And this bleed was spontaneous. It was a bleed in my left ankle. It was spontaneous, and it was really bad for no apparent reason. So I went back to my treatment team. And at this point in my life, I'm highly engaged as a patient. I went to my nurse and I said, there's something wrong. I don't know what it is. I'm giving myself my prophylaxis. I'm a quote-unquote good patient. But I just spontaneously bled in my left ankle. And then I showed her all this data. I pulled out my phone and I said, look, 5 times in my left ankle. I bled once, but it was really bad. Look at how much product I gave myself in this month. And then look, it was spontaneous in my left ankle. And so she said, all right, there must be something wrong. So she sent me to do radios of my ankle, and it turns out that I have extensive joint damage in both my ankles, but in the left ankle it's much worse, and there's a protuberance in the joint that is constantly biting at my synovial, couche synoviale in French, so inside the ankle. And there are microvessels inside that, and that provokes bleeding. And all this I know because I pushed the conversation, I asked questions, and then she took out charts and she showed me, she explained everything exactly how it works. So now I understand how my ankle works and why it bleeds for no reason, and why it's very important for me to respect my prophylaxis. But following that, they changed my treatment plan to give me a more intensive prophylaxis. So I went from every 3 days to every 2 days. Because of my left ankle, and this is 2019 so far. 1 in my left wrist, of course. That's from typing because I write a lot at work. But my left ankle so far has not bled. I think that MyCBDR gave me a better understanding of my hemophilia, a better understanding leading to better self-management, and this led to concrete clinical outcomes. And actually, if I pulled out the charts from 7 years ago, I would bleed 30 times a year. This year I bled once. And this is really going with the time I was getting more engaged in my care and when I started using the app. So the app was really a vector for me to collaborate and partner with my healthcare team. It allowed me to get more engaged in my healthcare. Now I'm really in control. I self-manage, and I can say that thanks to my CBDR, I am now much more emancipated from my illness. So this was intended to be a concrete example of how a digital health tool can really help a patient in their life with illness, but also the healthcare team to partner with that patient. And I would just like to finish with a thanks to the team at MyCBDR and Alfonso Iorio for the great work. They always try to involve patients in the process, and I think that this really shows. Thank you.
My name is Dr. Laura Copeland. And I started my medical career many years ago as actually as a secretary in a family practice office, and then I became an office manager in a family practice office. And then I went to medical school, and I became an emergency physician. And shortly after becoming an emergency physician, I found myself sort of voluntold to implement a health information system in the emergency department at the Cleveland Clinic, which was the beginning of another career. Not that I knew that at the time. So now I am a medical informaticist. And I did move back to Canada, and I did spend the next 10 years of my life working at Humber River Hospital, where I was the physician charged with leading their 600 physicians into North America's first fully digital hospital. I left there about a year ago so that I could join Health Tech as a consultant and wander around Canada to talk with other organizations who are trying to leverage technology in patient care. In the meantime, I also did a change of scope of practice because I found it was really hard to be a medical informaticist and be the kind of medical informaticist I needed to be at this point in our history, and an emergency physician at the same time. The breadth of practice was too much, and nobody really appreciated my sleeping through meetings. So I changed to medical psychotherapy because it turns out I was doing an awful lot of that anyway along the way. And I then now practice as a medical psychotherapist, doing probably about 20% of my practice using OTN virtual medicine. So the point of this very lengthy introduction, in addition to letting you know who's standing here, is that I wear many hats, and certainly have worn many hats in my life. And in addition to the hats that I've already mentioned, I also have my mom hat, and I have my daughter hat. And when I hear Mathieu talk about his experience, I really want to put on my patient hat, because not only do I have two boys that have severe hemophilia, but recently it's been recognized that my carrier state is a little bit more than that. I have pretty significant bleeds. I've had joint bleeds, spontaneous ones. I had a 6-hour appendectomy. So I probably am not the most normal carrier, and I now call myself a mild hemophiliac and have my little medical alert. So that's my patient hat. And another thing that I get from listening to Mathieu is that though I would love to go putting on that hat and say, yes, I can relate, I cannot take off any of my other hats. I will always have that physician hat. I will always have that hospital administrator hat and consultant hat. And because of those other hats, I can no longer truly relate to being a patient and feeling isolated and afraid and not knowing how to connect with my healthcare system. And so if there's one thing that I have learned in my journey, it's the importance of knowing that I can't take off that hat. And recognizing that means I have an obligation. I have an obligation to talk to my patients. And I have an obligation to encourage hospitals to have patient advisory committees. So what are our obligations as providers and administrators? I think we all need to recognize the limitations of our perspective. We need to be asking our patients what they need, what they want, what they hope for, most importantly, what they fear, because that is really the thing that we lose first. We need to engage patient advisory committees, and I might say, patient subject matter experts to participate in all stages of planning. We need to be measuring health outcomes that are what's important to the patient, not really what's important to us. And in the end, we need to be asking for feedback of how are we doing? How did we do with that change? Is it better or not? And then using that feedback to move to the next step. So let's be a little bit more concrete. What does it look like to engage patients? As a provider, engaging patients involves asking them about what their goals are instead of assuming that I know. And as a physician, I am trained to fix it. I must fix it. That's my job. You diagnose it, then you fix it. But that's not necessarily what it's all about. It's really about being a participant in my patient's journey. And I'll give you a little bit of an example. So my bipolar patients, I think I started out in medical psychotherapy being very frustrated by why can't I get compliance? And then I realized compliance is not the right word. The politically correct word is adherence. But the problem is it's all the wrong perspective. It's not about why can't I get them to take their drug? It's about why can't I speak their language and understand what's important to them? Because taking their drug is not what's important to them. What's important, as a matter of fact, staying out of the hospital isn't all that's important to them. What's important to them is feeling good about themselves and looking good. And those medications, they make them feel kind of flat, and they make them look kind of fat. So patients don't want to take their drug, and they don't understand the importance or the contribution that the drug has to reaching their own goals. So if I can change the way I talk to my patient and start talking about how can we make you feel good and look good and really work with them to adjust their medication and be engaged in their care, then we're all going to be far more successful. Now, putting on my consultant hat, how can I be more strategic and engage my patients better as a consultant? Every time I do engage with a hospital, I'm looking around to see if they have a patient advisory committee, and if they're not, I can consult and say, hey, you probably should have one. And then I can ask some other interesting questions. For example, you have a patient advisory committee, but I'm wondering, how do you define who your patient is? Because in mental health, it might be that your patient advisory committee has been defined as all those people who have access to your healthcare center, which is lovely. But what about the thousands out there who don't have access? And what about the thousands out there who don't even know that they have a mental health problem that could be helped? Are they your patients too? And how do you engage them? So some questions to think about as organizations engaging patients. I think it's very important that all hospitals have some process in place of how they engage patients, and that they're using patients on every kind of planning and strategic process that they're considering. And it might even be on things that they don't think that patients really have much input to. So for example, I was involved in a physician's documentation standards work, and this is very common stuff for somebody who does health information system implementation, because you have to create electronic templates to document for the physicians to document about their patients. So I guess the biggest question when you think about physician documentation is it physician documentation? Certainly, we tend to think it is, but in 1993, the Canadian Supreme Court made it very clear that it's the patient who owns the content of that record. The provider owns the physical record, which I think could use some clarification as we move into the virtual world. So what is that physical record? Does the patient own their data? Does the patient know every place that data goes? And shouldn't they? So as we think about physician documentation, or whatever it is that we're creating here as physicians to reflect the patient journey, I have to admit to you that I have no idea what to do anymore, which is a really good clue that it's time to have more conversations. What is my record, and what is the patient's record? If I'm talking to somebody and documenting their journey, their story, and I have a thought of, did you see how that patient reacted to that comment? I think there's something more there. I think we have a history of maybe child abuse or some history of sexual abuse that isn't coming out. And I want to remember that, because that's going to be really important to helping this patient along the journey. But I don't think they're ready to be hearing that, because that's just not where they are in their journey. But I want to remember it. How can I document that? How can I make a note of, okay, off to the side, next time they come in and you're talking about that, just pay attention. Is that something that we need to go to? But I have no place to put that, because I don't have really my place to put notes and the patient's place to put notes. So I think we need to rethink some of this. Also, some things like psychotherapy. I can't tell you how uncomfortable I have been as an emergency physician when you open up somebody's chart and you're hoping to find out some information about the medication that they need to have in order to perhaps control some of their symptoms, and you find an entire history of all these very, very personal things that you really didn't need to know as an emergency physician. And so are we having these dialogues? And I think the problem is we're not, but we should. We should be engaging with the patients and talking about, well, what is this chart? What is useful to you? What's useful to me? Where do we put all of these things? And come up with something new. We need to include the patients in the approval of our design. And of course, we need to make sure that our patients have access to this record that is theirs. So, one of the things that I have very much enjoyed doing, and perhaps a hat that I have very, very much enjoyed wearing over the last year, is as a member of the Health Standards Organization Technical Committee for Virtual Healthcare. And on this committee, I got to sit on a panel with several patients, like Mathieu, and engage together in these dialogues. And I have to admit, I'm not finished. I want to keep talking to him and other patients. But I'm going to hand over the podium right now and have Amy Pack explain to you a little bit more of the process that we went through at the Health Standards Organization to come up with virtual care standards. Thanks.
Forward, I'll be talking about how HSO involves patients in the standard development process and within the content of their standards that govern virtual health services. So I'm an experienced program manager that heads the standard development process at Health Standards Organization, and I work closely with patients to develop these standards. And most recently, we have developed a virtual health standard that was published in November of last year that I'll discuss more about the scope and content later. But basically, through this unique experience of collaborating closely with patients and also a variety of other experts on the technical committees, I've really been able to remove myself from my more technical background in law and science and genetics and really look at the actual impact these standards have in the healthcare system and on the patients that are ultimately receiving these virtual health services. So at HSO, we really strive to build standards that unleash the power and potential of people around the world who share our passion at achieving quality health services for all. That is achieved through a rigorous structured process that follows ISQA standards and also follow the Standard Council of Canada requirements. And this leads to a very unique standard development process in place by HSO to develop standards that are safe and efficient for patients. But our key to the methodology in developing standards and really unleashing the power and potential of people is through very purposeful partnerships with experts on the field. So with every standard we develop at HSO, we make sure to have the right people around the table. And this includes a balanced representation of individuals that really allow us to have a full picture, not just the picture from a legal perspective or the picture from a provider perspective, but you'll see that we engage 4 distinct categories of stakeholders. So the first of which is policymakers. Then we go on to general interest category, which is often the academic side, the research side. And then we have product users. So depending on the standard, it's clinicians that are using virtual health services. And then finally, we have the 4th category of patients and family members. And this category is individuals who have significant and recent experience assessing and using health or social services. So this really allows us to have a full picture of where the current needs are, what the current technology is, and what might be the future technologies to consider in the standard. But HSO really goes a step further and not only engages these people, but within the recruitment process, we make sure that all individuals on this technical committee understand and respect the immense value patients have in not only being the expert of their condition, but more broadly, the expert of their experience within the healthcare system, especially in the case of hemophilia, where you're constantly requiring monitoring, and not only at home using apps, but in constant relation with healthcare providers. So we employ this rigorous methodology within the context of the virtual health standard. We really made sure that this standard was developed in partnership with all the expertise of the technical committee. Laura and Mathieu were a crucial part of this technical committee to develop the standard. And the standard was designed around patients to empower individuals in their own care. So having those authentic discussions with a variety of expertise really allowed us to determine what scope the standard should have. So especially considering the intricacies of virtual health technologies, that is a fast-moving field and also very broad in scope geographically speaking. So we had to make sure that the standard had international considerations, and also that the standard was able to apply to large hospitals, community centers, as well as patient homes, and understand all the implications of those different contexts. So I'd like for you all to take a step back and really understand the scope and the value of this virtual health standard put in place by HSO by thinking of the patients that would certainly benefit from the standard and that currently benefit from virtual health services. So start thinking about an individual from an Indigenous community living remotely and requiring healthcare services. What about a child that has a rare genetic disease, yet their only expert that they can access for critical care is in the UK or abroad? What about a mining worker that is placed remotely only for a few months a year and that requires routine checkups? Or in the case of Laura and Mathieu, hemophiliacs that may live in Toronto and Montreal in metropolitan cities with great access to healthcare, yet they need remote monitoring on a constant basis. So you can really see that everyone can benefit either directly or indirectly from virtual health services. And the virtual health standard really is in place to maximize the access to virtual health services, and not only virtual health services at large, but the safe, efficient, and thoughtful virtual health services. So at HSO, we make sure to employ a people-powered approach across all dimensions. This includes from conception to publication of our standards throughout the entire standard development process, but also within the integrated content of our standards. By collaborating closely with patients, we make sure to develop standards that revolve around patient dignity and patient need. We want to make sure to encourage organizations and government that have a hand in virtual health service delivery, but as well as virtual health service governance and guidance to understand the concrete value of involving patients, and even go above and beyond that and start implementing measures and strategies in place to engage authentic conversations with patients just like Mathieu. Thank you very much.